therapy or prognosis of the cases, and based on this physical, this staging system is based on the physical, radiologic examination, bone marrow biopsy, and aspiration reports. And this another staging system is now is in use. The B symptoms includes the fever, weight loss, and more than 10% of the body weight, and night sweats. So there are 4 staging systems. Now shortly about the mantle cell lymphoma. So the mantle cell lymphoma, they are of B cell origin, they are aggressive lymphoma, and they are arising from the mantle zone. The morphologically, the cells are maybe small size lymphocytes like a normal or mature lymphocytes, or intermediate size is a clip team called clip nuclei. Immunophenotyping, the cells are positive for surface immunoglobulin. Lambda is more than the kappa, and they are positive of B cell marker, that is CD19, 20 and 22. Interestingly, they are also positive for the T cell marker, that is CD5, but they are negative for CD10, CD23, 11C, HLA-D are positive, 43 positive. Because these markers are very important when we are morphologically we are seeing any mature small lymphocytic lymphoma. There are so many mature small lymphocytic lymphoma. So we need marker study to differentiate all this lymphoma. So if we take this CD25, then it can differentiate from other CD negative lymphoma like follicular lymphoma. They are in the same category of small mature lymphocytic lymphoma. Again, similarly CD23. CD23 is positive in CLL, but here it is negative. This mantle cell lymphoma, they represent the 6% of all lymphomas. It is a disease of the adult with a median age of 63 years with a male preponderance, and usually at the presentation there is wide dissemination of the disease. There are multiple lymphadenopathy along with splenomegaly. Some of the patient, 15 to 30% of the patient presented with gastrointestinal symptoms like our case because of lymphomatous polyposis in the gut. The bone marrow at the site of at the time of evaluation usually is involved in 60 to 90% of cases. Leukemic phase is noticed in 25% cases. CNS is involved in 9% of cases. However, these cases are aggressive lymphomas. They have a very poor response to all attempted therapies. Nowadays, the stem cell transplantation has come and is thought to be a curable disease with this stem cell transplantation. 5-year survival is 27%. In the pathogenesis, there is a transcription involving the chromosome 11 and 14. There is upregulation of BCL1. This is cyclin D1. This is a cell cycle kinetic which causes increase in the cell cycle cell proliferation, and this is noticed in 90% cases. So this is considered to be a pathognomonic of mantle cell lymphoma. In the lymph node biopsy, this is one follicle, and we can see there is expansion of this mantle zone. So they are small cells. This cleaving is very difficult to appreciate on light microscopy. There's very small cells and with little cleaving irregular nuclear membrane. This there may be 3 patterns. The diffuse patterns involving replacing the whole nodes, or there may be vaguely nodular pattern, or there is just increase in the mantle zone around a benign follicle. Large cell progressions is infrequent. The immunophenotyping, they are positive for this light chain CD19, 5, BCL1, and negative for CD10 and 23. Now, this is very important because this is one small cell lymphoma morphologically, and that has to be differentiated from other small cell lymphomas like follicular lymphoma, marginal zone lymphoma, and CLL, SLL. All these are indolent lymphomas. This is aggressive lymphoma because treatments are different in indolent lymphomas and aggressive lymphomas. The frequency wise, this is follicular lymphoma is 22%, marginal zone lymphoma is 8%, CLL, SLL is 7%, and this 6%. Age of onset is almost in the 60, around 60. Stages of presentation, this is one stage 1 disease at the presentation, others are stage 3 or stage 4. Response to therapy, this is very poor response to all the therapies in comparison to the others. 5-year survival is again is very less, 21% in comparing to the other categories. So hence it's very important to differentiate from the other small cell lymphomas. Predominant site, these are nodal, this is nodal, we are mainly nodal. This is marginal zone lymphoma, usually arises from the spleen. This marginal zone is outside the mental zone. There is another big monocytic cell layer. This is called marginal zone. So these cells are lymphomas are arising from this marginal zone, outside the mental zone. Usually this marginal zone lymphoma arises from the spleen. That's why it said it is extranodal. The pattern of the nodal infiltration is follicular. In case of follicular lymphoma, in diffuse, it may be 3 types. Then benign cell equivalent. This is arising from the germinal center. So usually they may be of small clip cell type, they may be of large centroplastic size or centrocytic type. This is marginal zone lymphocytes arising from the marginal zone lymphocytes outside the mental zone, and this CLL, SLL arising from the mature B cells, and mantle cell lymphoma arising from the mental cell. The dominant cell type, the small clip cells, in most of the cases in grade 1 and grade 2, and grade 3 cases again is centroplastic type. In marginal zone lymphomas, there's mix of small lymphocytes and plasma cells. In small cell lymphoma is small lymphocytes, and here also again the small lymphocyte. Plastic transformation is less. Immunophenotyping, they are positive for CD19, 20 and BCL2, and negative for CD5. This is important to differentiate from this because this is CD5 positive. Again, this case is very important to differentiate from this. Again, this is CD5 positive. However, the SLL and mantle cell lymphoma, they are differentiated based on CD23. This is positive in SLL and CD23 is negative in mantle cell lymphoma. So for the diagnosis, you require the full panel. Otherwise, it's very difficult to diagnose all these subclassify these small cell lymphomas. Molecular level, there is 14-18 translocation in follicular lymphoma, which is characteristics of this lymphoma. This trisomy 3, trisomy 12, and again here this 11-14 translocation is again very characteristic of mantle cell lymphoma.